Good afternoon and welcome to Grand Rounds today. Today, it is my great pleasure to reintroduce Dr. Selden Spencer. Dr. Spencer is a board-certified neurologist, polysomnographer, and neurosonologist, and he has very kindly accepted our invitation today to provide us with a review of stroke and dementia. And please welcome Dr. Selden Spencer.
Okay. Well, thank you all for being here, and thank you for all who are viewing remotely. This is, let me tell you the background of this talk. They came across a couple articles that talked about a possible treatment for small vessel disease of the brain. And I said, well, geez, maybe I should give a talk about that. And then lo and behold, the CME committee said, well, hey, why don't you talk about dementia as well? And I think that's appropriate, but I'm going to fly like a bird because this is a complicated subject and I have my own perspectives on it. And I guess I need to tell you from the outset that this is not hopefully reflecting my partners, Dr. Kitchell, Dr. Clemens, and Dr. Ramich. They may or may not agree with me on any of this, but I think it's out there for your purview, and hopefully you'll get something. And I also want to say thanks to Tim Hextra for helping me get the PowerPoint together, and to Sally and Nicole for just hosting these conferences. Okay, so stroke and dementia, as I said, I don't have any disclosures. You saw that several times. And this is the outline in case you pass out somewhere during the program. I've got basically 4 chapters. The first one is what's new in cerebral small vessel disease and stroke. Number 2 is what's new in dementia and Alzheimer's disease. And then number 3 is what's crazy new in stroke and dementia. And then number 4 is 2 slides, what is reality and where are we now and what we can do practically. All right, so this is the outline of chapter 1. What is a stroke? Distinguish large vessel from small vessel disease. I give you case 1 and case 2 to talk about a little bit. Talk a little bit about small vessel disease. And then this drug, cilostazol, which has been around forever, but there were 2 recent studies, one in the UK, one in Japan, that tout the use of cilostazol in helping people with small vessel disease and how that drug works, and then talk about dementia. So here we go. This is a stroke. Gee, I've never seen that before, but here we go. You have artery applying blood, carotid into the middle cerebral artery, and you can see the middle cerebral artery is a little junky, but then there's a clot that somehow goes into this area and plugs it off, and you kind of wipe out a big territory. This is large vessel disease, damage to the brain due to reduced blood flow. We've got this down. However, I want to talk a little bit about the difference between clinical and imaging findings, and this refers to the whole concept of TIA, transient ischemic attack. We have people that will suddenly present with perhaps some difficulties with their speech, and then they'll come to the emergency room, and within an hour or 2, they're back normal, and everybody's nervous, so we put them in the hospital, and lo and behold, the next day when they do an MRI, lo and behold, there is some injury, new injury on diffusion-weighted image. And so now the question is this a TIA or is this a stroke? Well, it's a stroke. She had damage to her brain, even though she's back normal. So this is an ongoing struggle. In fact, there are some people that want to ban the idea of TIA as a concept. But let's go back to the idea of large vessel versus small vessel. You all are familiar with the mnemonic FAST, face, arm, speech, time. You have a sudden loss of speech, a sudden loss of strength, a sudden loss of facial strength, drooping of the face. You get to the emergency room and they try to do the CTA, look for an occlusive element in the large vessels, and they try to get rid of it with TPA or tenecteplase and embolectomy if worse comes to worse. This is well established, and I'm very proud of Mary Greeley. I think they've done a very good job, courtesy of Sharon Elrick and Ashley Robson and the committee, the paramedics, the emergency room, the radiologists. We do well with that. But I want to talk about small vessel disease, and I think the memnotic would be slow. We don't really have a good sense of how this accumulates, and I'll talk to you a couple cases about that in a moment. And I think we need a Venn diagram here. So here we go. Now this is sloppy Venn diagrams for stroke and small stroke. I personally drew these because I've shown this before, and the idea is that a lot of strokes are due to the carotid artery being bad and junk going up into the brain. A lot of strokes are due to junk coming from the heart, from the left atrium, from atrial fibrillation and plugging up an artery. But a ton of stroke is due to small vessel disease. A small bunch is due to genetic problems, clotting problems, reactions, methamphetamine, things like that. Now, if we look at the small vessel disease, you can see there's a ton of different pathologies going on. We have no clue. We really don't dice this out very well. There's arteriolosclerosis, the kind of thickening of the little capillary wall. There's amyloid angiopathies, there's hypomyelination, there's perivascular space, and I'll get into that. So, here's case one. 71-year-old or a 70-year-old man who lost his auto repair job in 2015, so that's about 8 years ago. He has a history of hypertension, hyperlipidemia, heart disease, head trauma, smokes, drinks alcohol, has ongoing dental infections, which would be a whole nother topic. Had an evaluation in 2020 with his SLUMS test, and that's St. Louis University mental status test, 11 out of 30. You want to be 30 out of 30. 11 out of 30 is bad. He's a fellow, he didn't want to be in the office. He is apathetic. He really can't communicate very well. He can't walk very well. And so, you know, kind of lame, I put him on some donepezil and memantine, which is FDA-approved drugs. He did wind up reducing his tobacco and alcohol use, and given that he was getting worse, I repeated the MRI in 2023, and it suggested that there's still more small vessel disease damage. He's still safe at home, but having trouble with dressing at times. So this is his MRI. This is 2019. You can see small injuries, bang, bang here. This is not large vessel disease where you get a quarter of the brain taken out. And then you see more. It's worse here in 2023. I hope you can agree. I tried to line up these slices as best I could. Here's case two, 73-year-old educator who got wobbly with her gait in 2018. It was a specific event. She was visiting family. She actually went to this emergency room. She was thought maybe to have had a TIA, but she was better by the time she was in the emergency room, and she was told that her MRI was abnormal. She was not crazy about medical care, even though she had some chronic medical issues. And in 2021, she was in danger. She was leaving doors open in her house. And given that she was not safe, she moved in with her friend, and her testing showed a value of 14 out of 30. Again, you want to be 30 out of 30. She's not right. She's having trouble with speech. Her interaction is very strange as far as you're trying to carry on a new subject and she's still stuck on the old subject. She can't move on. So these are her images. And you see here in 2018, she has white matter damage. Again, the surface of the brain is gray matter and is a lot of neurons and cortex. White matter is down here, and you can see the damage in 2018. And it's much worse in 2023. It's contiguous. And she's getting worse. So these are the questions. There's more ischemic damage, and we don't know the mechanism. Are there any specific symptoms to identify? And truthfully, it is gait, worsening cognition. Are there any meaningful treatments? Have we missed something? As always, you make sure there's a B12 deficiency or something like that. Is this vascular dementia then? Is this small vessel disease? What is small vessel disease? Is this due to cardioembolic large vessel disease? You can have both, right? You can have a large vessel stroke as well as small vessel stroke. And then we're always stuck with this fine quote here at the bottom. No acute or subacute infarction. This is on the MRI. This was a radiologist talking. Mild multifocal periventricular white matter T2 hyperintensities, which is nonspecific, but most likely represents the sequelae of chronic small vessel ischemic disease. Everybody scratches their head and say, well, what am I supposed to do with that? So I'm showing, this is actually from 2017, and I don't have the reference listed here, but this is small vessel disease in the perspective of this one investigator. I mentioned already arteriolar sclerosis, which is thickening of the small vessel wall, and it gets progressively worse with time. This doesn't look too much different from perivascular space dilatation, and Dr. Larson, who is not here, will love to use the French word état crible. I never say it right, but at any rate, you get enlargement of the perivascular space. Whether that's a problem with the artery or a problem with the surrounding tissue, we'll get into that. You get places where there's myelin loss. And then I have not really commented much on hemosiderin deposition and what that means, but I do see cases of amyloid angiopathy where amyloid is investing the wall of the small artery. But we get these types of MRIs, and you can see this hypomyelination back here, and then you see the dot, 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 bop, 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 all these injuries. Something's going on, and it progressively gets worse, and the patient gets worse. And we are very poor at diagnosing and treating this. So then we get these two articles that come on. This one is actually from 2020, but the stroke symposium in January had an update by this group out of UK showing salocitazole for secondary prevention of stroke and cognitive decline. I said, well, that's pretty important. That's pretty good. Actually, their data from 2020 is here, and it's not that impressive, but they eked out a little significance for salocitazole improving condition in these people that have small vessel disease. My motivation came from this article, which is from Japan in February, talking about the role of salocitazole in secondary prevention of stroke, and it's a little bit more impressive. And this is the summary. They put people on aspirin and salocitazole versus just aspirin or clopidogrel, and could show that they would have fewer strokes, and they had as good, if not better, safety outcome. Boom, boom, boom. I said, well, we got to do this. We got to do this. I think this is important, so let's do grand rounds and talk it up. Now, my nurse Aspen is not here, but she would urge you to not do salocitazole because it's not a free lunch. There's nothing simple about this drug, and it's not certain it would be beneficial. But I want to get your idea and your mind thinking about a small vessel disease. What's happening in the brain with these small vessels is different than what's happening with a carotid or a middle cerebral artery or with the heart. And frankly, the small vessel disease in the brain is quite different than small vessels in the kidney or the liver or any other place. Partly because there's a lot of neural input from cells of the brain. All right, now, this is salocitazole. This is your summary slide. This drug is already used and to help claudication, and just look at the bottom part. This is a summary slide. Salocitazole reduces damage to the lining of the artery. That's got to be a good thing. Reduces the swelling and enlargement of the muscle of the artery. That's got to be a good thing. And reduces inflammation. Again, it's not very expensive, but everybody gets side effects. The first person I put on it wound up in the hospital with diarrhea. So it's not a slam dunk. And this is not FDA approved for this purpose. The American Heart Association is not urging people to go on this, but I'm just throwing it out there and trying to bring you up to date on what's out there. Okay, we're done. Chapter 1 is done. We're going to talk about dementia. That's pretty easy. What is dementia clinically? And I think it's very important that we use the proper words and for the sake of our patients and for one another. And what about vascular dementia versus Alzheimer's disease? And I'll show you a couple of Venn diagrams there. Then I'm going to wade into Alzheimer's disease, the proposed pathology, some historical tidbits, what I actually really like, and I'll try to be brief about that. Talk about the genes and markers. And then what you really came to hear about are these monoclonal antibodies. It's a mABS scene. That's my one joke. All right, we'll move on here. So, and then also how you measure dementia is important. So, to me, dementia is memory impairment plus one other cognitive domain that's impaired, and the person is unable to function independently. That's the crucial element. I don't want to use the word dementia until the person is not safe to be home alone. Okay? Mild cognitive impairment is just a wonderful term that is very vague and just says they're having trouble. But they're still safe. They can function independently. So, causes of dementia and some reversible. Mild cognitive impairment, as I said, is very convenient. About 15% of MCIs, this is according to a Kentucky trial, come back to normal for a time if issues are resolved. And I've seen this. You get a person out of isolation, you get a person treated their sleep apnea, you get them off alcohol, treat their B12 deficiency, they do better. But by and large, 10% of people diagnosed with MCI evolve into a dependent dementia every year. So I'm going to speak to causes of dementia like stroke and neurodegenerative disease. And as I already mentioned, I think vascular dementia, which the first two cases represented, have problems with gait and speech. And Alzheimer's is really more memory, behavior. But this is courtesy of Dr. Oz. I guess I should give him credit, whatever. But this is a healthy brain. This is Alzheimer's brain. Please characterize some of the features here, one of which is the volume is less. There's less brain, particularly in this area, which is the hippocampus, which is crucial for memory. You can see this is dilated and swollen up. Not shown here as much in the way of stroke. Maybe these are. Anyway, this was not the purpose of this slide, and I'll talk about that on and off as we go along here. But please see this shrunken, hard brain. I'm going to come back and talk about brain volume and hardness as we go along. Now, there's going to be two slides about pathology, and I refer to it as the ugly pathological reality. This is a very solid study from the NIH looking at pathology of demented people. That is, they've died, they've gone to autopsy, they looked at their brain. So, they have 604 people that had Alzheimer's disease pathology. However, there were 294 of those 604 people that also had vascular disease and ischemic damage to their brain. There were 408 of these 604 patients that had Lewy body or synuclein pathology in the brain. So please get the idea that it's a mixed bag, and pure culture Alzheimer's disease is tough. It's not easy. Mixed pathology. Okay, so here is a recent one, just 2023, and it's kind of interesting because they looked at the trends, looking at people born in 1905 versus 1925, and showed some trends that actually amyloid burden in the pathology is going down, whereas tangle pathology is going up. But for me, what was interesting is severe atherosclerosis. I'm talking about the carotid artery, big arteries, is going down, but small arteries, chronic microinfarcts, is going up over time. So, this is the standard. Now we're going to talk about Alzheimer's disease. This is the amyloid hypothesis, that you start getting the amyloid beta accumulating in the brain, which then leads to tau, and I'll talk about this momentarily, to accumulate, and then somewhere along the way it hits a point where they get mild cognitive impairment, and then they get demented as this whole process continues. These are the cartoons. I've used them before, but they're very relevant. This is the amyloid precursor protein. It's a molecule that sticks in our membranes and is very crucial for synapse development and is cleaved at one point or another. I think back in the 90s and 80s, there were efforts to use enzyme blockers, beta secretase blocker, total disaster. But at any rate, what happens is to propose that these, at some point or another, this molecule, which is very useful, gets cleaved, and you have this beta amyloid fibril. Now, unfortunately, it can accumulate and not get cleared, and then you get this junk around the side of the cell, and presumably that impairs the cell to the point that the neurofibrils collapse, the cell doesn't work, and you get the tau protein, which is the feature of Alzheimer's disease, plaques and tangles. So now indulge me on a little historical journey. This is Alois Alzheimer, and he's a pretty unusual character psychiatrist. And this is the index patient, Auguste Dieter. She was placed in an insane asylum in Germany, in Munich, in 1901 at the age of 51. Again, important to note, this is young. She died 5 years later. A couple of interesting features is that the family couldn't afford to keep her in the insane asylum, and so Dr. Alzheimer paid for her lodging in the insane asylum. In reward, he was able to do the autopsy, dissect her brain, and applied a dye called Congo Red. I'm going to talk about this a little bit more because it's just weird history. And it wound up being very specific for amyloid. You know, I just showed you the pictures about amyloid. Now, this is just sort of for my amusement. He presented his paper in 1907, and it was not well received. And part of it was he was the first presenter. The second presenter to the group of psychiatrists was talking about compulsive masturbation, and everybody thought that was more interesting. So they moved on from there. That's sort of a joke as well. But anyway, a couple more wrinkles. You see this guy, he's got the same tie and shirt, but he's black. This is a guy, Solomon Carter Fuller. He was born in Monrovia, Liberia, and trained in the United States, went to Germany and was lecturing and teaching in Germany, and reportedly in a lecture 5 months before Alzheimer did his presentation, presented the same information about amyloid pathology in the brain. Just very strange, and a couple things to wrinkle on this. Where does the term Congo Red come from? Well, it turns out in the 1850s, there was a big push. Congo Red was found to be a dye that wouldn't wash out of the fabric. And the chemistry was created in Germany. It has nothing to do with Africa. But Germany was keen to colonize Africa. And so they named all these different dyes, Congo Red, Sudan Black, and Alzheimer, 50 years later, used Congo Red on brain tissue rather than fabric and found what he did. The Germans were very enthusiastic about Africa, and in the 1850s were bent on colonizing it. King Leopold got control of Congo. Germany got control of Namibia. This is going to get weirder and weirder, but they basically, both Belgium and Germany, committed genocide, killed off native populations as best they could. And one of the leaders was a man by the name of Goering, who wound up being the grandfather of the Goering in the Nazi Germany that committed genocide on the Jews. So a lot of crazy history. The only reason I brought up the Liberia thing is because these were freed African slaves that were already brought over from Africa to the United States and then sent back to Africa to colonize it. And Liberia did the same thing as the Germans. They invaded this coast of Africa, whether it be the state of Georgia, state of Louisiana, state of Kentucky, and destroyed the native populations and set up their own country. All right, on that happy thought, let's move on to this person who died about 10 years before I started residency at the Washington University in St. Louis. He was a member of the Nobel-winning prize group at WashU in the 40s for discovery of the Krebs cycle. And as far as anybody knows, he did not have any dementia. He died of a heart-related thing in his 80s. And his autopsy was loaded with amyloid. All right, so you're not going to sit here and tell me, oh, well, grandma smokes 2 packs of cigarettes a day and doesn't have any, heart or lung disease. Exceptions don't make the rule, but this has always jaded my opinion about the Alzheimer's disease and the amyloid hypothesis. Okay, now let's get back to business. This is painful, but sort of necessary because we identify people with Alzheimer's and dementia based on apolipoprotein E characteristics. If they have a double LL E4, they have an 8-fold risk of disease. And I'm going to come back to this when we talk about some of the treatments. Whereas if you have a double LL of the E2 variety of apolipoprotein, and what is apolipoprotein? It's basically something with lipid metabolism, but it has a risk or a benefit with regards to dementia. There's other genetic features that we don't hardly ever see. And then I talked about the amyloid precursor protein. Errant cleavage leads to the beta amyloid that gets into a plaque and causes cellular dysfunction. Tau is and I just want to say a brief thing about tau because there's been an interest. This is a protein. I showed you the collection of the axonal protein. There has been an interest, continues to be an interest that acts like a prion. I think you've heard of mad cow disease, and this is not a bacteria, not a virus, but a protein that has the ability to migrate and cause damage elsewhere in the nervous system. Okay, now bring on the mABs. So the idea, as you remember, is you have the fibrils. Why not develop an antibody to go in and grab those fibrils and get them out of the system? Great idea. So here's aducanumab. These are all sponsored by very prestigious pharmaceutical companies. There was the eMERGE trial, which was positive. ENGAGE trial was negative, and they have an ongoing trial with Envision. There was an FDA approval based on this rather lame evidence. A lot of uproar, so that's still undetermined. There's 2 other monoclonal antibodies that have been tried and unsuccessful. Donanemab is Trailblazer trial, and 123 is still proceeding and beneficial. And I need to give a shout out to Eddie Clemens, who actually has 2 patients that are in the Trailblazer trial. So if you want to talk to somebody who in our clinic or our environment has some experience with that, it would be Dr. Clemens. Lecanemab is the one, the Clarity trial came out in January. Oops, sorry. This also caused a lot of stir, and there was a benefit with regards to the CDR score, and we're going to talk about that because that's not a MOCA, it's not a multiple system, MMSE or a slums test, and I got to go over that. But anyway, they were able to show with this monoclonal antibody, securing the amyloid and sucking it out of the system, that they had clinical benefit and they also got rid of the amyloid. That's a good thing. However, always being a little bit jaded about these things, there were adverse trial events. 25% of the people had a thing called ARIA, which is amyloid-related imaging abnormalities. It's usually asymptomatic, but you got to stop treatment because they get swelling of the brain. And there were 2 deaths related to this. And unfortunately, the ones that did the worst were the ones that were apolipoprotein E double L, who are at higher risk for getting dementia. Now, I was impressed, and I guess I'll say that again somewhere along the way. There was an NIH guy that reviewed the studies, and several people have emphasized, I showed you earlier how the brain was shrinking and getting smaller. It is documented that in the people that were getting the monoclonal antibody, they lost a tablespoon of brain, 3 teaspoons. I think it's sort of the size of a cherry tomato. I'm not going to eat it, don't worry, but just throwing it out there that there was a problem there. So should everyone get a monoclonal antibody? I think the patient selection is going to be very difficult. Who benefits? And I think it's good, but I'm going to talk about other ways to get rid of the amyloid. Different trials are using different screenings, but at a minimum, this is going to be very expensive. Currently, you have to have an amyloid PET, and then you have to have the CSF amyloid biomarkers. Hopefully, this will all go into more of a plasma sampling method, but not now. The drugs are costly, workup and monitoring, infusion are costly, so realistically, you've got to be in a clinical trial sponsored by Lilly or Biogen or somebody like that. My old rag about vascular versus neurodegenerative disorders, so I want to go on my high horse again and talk about a clinical trial that's sponsored out of Indiana, and it is focused on young Alzheimer's disease. Remember, Augusta Dieter was 51 when she was committed. So this has merit. They're looking for patients that are dementing at age 50. But I was interested that one of the exclusion criteria is they can't have more than 2 subcortical lesions. I mean, I started my talk talking about how common it is to see these subcortical lesions, even if they're asymptomatic. So here, and Mike and everybody else may have some different opinion, but I'm basically trying to shunt people to places that are having a clinical trial going on. Okay, now, how do we measure cognition? This is what we do. This is the St. Louis University Mental Status Exam. This is the MOCA. This is the Mini Mental Status Exam. These are direct interactions with the patient to test their cognitive function. They're not perfect. They all have their pros and cons, but this has not been the measurement in any of these clinical trials. This is the way they measure cognition. And you have to be trained to do the clinical dementia rating scale because you basically subjectively ask the patient and ask the caregiver how they're doing in these different categories: memory, orientation, judgment, community, home, hobbies, personal care. And you have 6 categories. You can be anywhere from 0 to 3. And 6 times 3 equals 18. You're really bad if you are a sum of boxes of 18. So again, I think we're not really up and running with doing this kind of thing. Okay, now, relax. We can go into the chapter 3, which is what is crazy new in stroke and dementia. And I'm going to talk about the microbiome and stroke, sleep and glymphatic drainage. This is another way of getting amyloid out of the system. Briefly, I'm going to talk about genes and aging and talk about RNA and the neurovascular unit. But I basically want you to enjoy the art because there's some very interesting visual things that have come out of all this. And that's kind of pretty by itself. Okay. So this is pretty. This is the microbiome of young mice versus old mice. Green is in young mice. Red is in old mice. And guess what? If you give an old mouse a young microbiome, you know what I mean by the microbiome? It's the lining of the gut. It's the bacteria. If you get an old mouse a young microbiome, they get better from a stroke. They don't have persistent damage from a stroke. Again, this is pretty nice looking. So anyway, the young versus old. And this is their summary slide. This is a group out of Texas. Start to the left, you have an old microbiome, which has lower small short chain fatty acids, and you then convert it to a young microbiome with high short chain fatty acids, and guess what? The lining of the gut does better, they have more integrity, they have less inflammatory immune changes that are going up north to the brain where there has been an ischemic injury. The short chain acid that is most valuable is inulin, and you can get that in asparagus and a couple other things, so enjoy. You know, you need to keep up your short chain fatty acids. Okay, this is number 2, talking about genes to modify aging and looking at stem cells. And this is a course or a series that I looked at. And again, visually, this is kind of pretty. What they lined up is how genes are changing with age with regards to stem cells. And they find a place here that they say, I think this is aging. So let's give the mice something in here that will prevent the aging and the isolation and the quiescence of the stem cell. So they did that, and they applied different things into the brain. Stem cells in the brain of the mouse are kind of along the paraventricle. In the human, it's kind of along the hippocampus. And stem cells can go on to do anything. They can be a new neuron, they can be a new astrocyte, and so stem cells are good. And so they found one drug called SS, which I assume stands for secret sauce, that helped. And they applied it to clinical. SS improves cognition in older mice. So this is a summary slide, which even I can sort of understand. If you're young, you have stem cells that migrate out and make all kinds of good things, make new neurons. Aging, not so much. But if you give them SS, they will. And does that have relevance to mild cognitive impairment? Sure. Alzheimer's disease. So loss of neural stem cells and neurogenesis and cognition is reversible, at least in this mouse model. So they're going to make a bunch of money out of this, I expect, somewhere along the way. Number 3, sleep and benefit of glymphatic drainage. I've gone over this before, but the idea is, how do we drain the interstitial fluid? How do we drain the fibrils, the amyloid fibrils out of the brain? Well, there is a way. There's a glymphatic drainage. It takes some arterial junk that goes over to the venous junk and gets out of the brain. Furthermore, slow wave sleep promotes glymphatic drainage. Okay, just a little reminder about what slow wave sleep is. That's this stuff. This is very high voltage, slow, 3 cycle per session. And you don't see this in hard, old brains. You see it in a young teenage brain. Very, very robust movement. Unlike being awake and very slow and slow voltage. And slow wave sleep is early in the night, not toward the end of the night. And unfortunately goes away as you get older. Look at the black, slow wave sleep gets worse and less and less and less as you get. So if we could reverse and make sure that everybody over age 60 and 50 has good slow wave sleep, maybe we get rid of the beta amyloid and we have a solution here. So again, slow wave sleep improves glymphatic drainage, is another outline of high voltage stuff, gets glymphatic flow and gets metabolic waste out of the brain. Now, how can we manipulate stroke? Well, you can play with this new neurotransmitter called orexin. And I'll talk about this, but this is relatively new on the horizon, last 20 or 30 years. And it has a powerful role in keeping people awake. It is bad in people with narcolepsy. So why not shut down the orexin and make people sleep? Very clever idea, and lo and behold, I got to take a pause because I spent a year at the University of Chicago zapping mouse brains. Oops, went the wrong way here. Zapping mouse brains or rat brains right in here, and I would look at these H&E slices, just verifying where I had injected, and there was just tons of these big cells. And I said, what the heck are these big cells? Well, they are orexin cells. And so this is new on the horizon, and perhaps a good way forward in treating dementia. So the role of a dual orexin receptor antagonist on Alzheimer's disease, sleep disorders, and cognition. This is even a more recent article that looked at the A beta positive people. They remember amyloid beta positive group are more prone to be demented, and he looked at the size of their slow wave sleep relative to the amount of amyloid beta they had, and lo and behold, if they had really healthy slow wave sleep, they had less amyloid beta. A very cute thing. And then they did this heat map, which kind of showed where the slow wave sleep was in the brain. So I propose that we start sticking needles in everybody's brain and zap that area and, get a lot of slow wave sleep. Just kidding, just kidding. Last one, RNA wildcards with the Neurovascular Unit. There are pretty pictures coming here, but I want to emphasize that I'm not talking about within the nucleus of the cell or within the cytoplasm of the cell. You've all heard of messenger RNA, transfer RNA, ribosomal RNA. There's all these other microRNAs that are floating around in the system, and I see articles off and on, and I said, what the heck is going on? They talk about long coding RNAs. But there is a guy, Iadicola, that creates these very pretty pictures, right? You get in your art again. This is the pattern of microRNAs related to the endothelium of the small vessel in the brain, which is not the same as the small vessel in the kidney or the heart or any other place. And then you see articles like this, the circular intronic RNA, blah, 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 delays endothelial cell senescence by regulating the blah, 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 blah. I think there's a future here, but I don't understand it, and I just hope you enjoy that picture. All right, party's almost open. I hope I haven't confused you too much, but this is the reality, and this is easy. So this is the summary of the slide, or the talk. Monoclonal antibodies will be a treatment option for dementia and Alzheimer's disease, but selection and monitoring will be intense and difficulty, and we're not anywhere near that. We're not going to see it in the next year or two. Stroke variety and brain circulation will continue to evolve, and treatments will change. I promoted again the salositol, but please understand that's not FDA approved for this purpose. It is not approved by the American Heart Association. There's just literature out there sorting. So as a practical matter, this is what I do with my patients. And I think you always have to be realistic, and you have to be supportive of the patient and just say, well, you're demented, see you later. You're in my way. I use the memnotic SWAMs, slow wave sleep, whatever you can do for your patient to celebrate sleep and to enjoy sleep and perhaps improve sleep. I can tell you very simply, as young adults, to the extent that you can raise your core body temperature passively before going to bed, you will fall asleep quicker, deeper, and longer. That's old school. But if a person has joint pain, or if they have sleep apnea or something like that, just pay attention to sleep. Weights, I think Peter Buck was, he's still here, and he already knows this article about brain-derived neurotrophic factor. You build muscle, you build brain. Building muscle in your arm will release a neurotrophic chemical called brain-derived neurotrophic factor, and you'll actually build more cells in your hippocampus. Aerobic, basic heart stuff, you stress your breathing and heart for 20 minutes a day is ideal. Mediterranean diets, fruit, vegetables. I already mentioned about the short-chain fatty acid inulin, fructans, try to get them going. And then lastly, social. I just hate it when I have people that are brought in, and what do? Well, I get up, have breakfast, and then I go and I sit in front of the TV by myself, and that's it. I think social interactions is the best way. Your ability to look somebody in the eye, try to understand what they're saying, and try to develop a response that is hopefully positive is a good thing. Obviously, if their interactions socially are just negative and they're beating up on each other, that's no good. I would end by saying that we are hardwired to be empathetic, to be altruistic, to be positive and loving. So if the social interactions are positive, do it. If they're not, well, you're probably better off watching a rerun of Gunsmoke and doing your crossword puzzle or whatever you want to do. Okay, so that's it. Stick me with a fork. I think I'm done. Swams. All right, bring it on. Who's got a question? Who's got a complaint?
Great job, Selden. I have two questions. The first one is the amyloid in the blood vessels of the same makeup as the beta amyloid in the Alzheimer's patients?
No, but I can't go any further than that. And actually, John Fleming, who's not here today, has teased me about that often. People that have systemic amyloidosis is not the same thing as the beta amyloid that we see in Alzheimer's disease.
Second question I have has to do with diet. You mentioned the small chain fatty acids. There's also some data, I believe, that the medium chain triglycerides, which break down to the small chain fatty acids, can help with brain function over and above what goes on in the microbiome. And that has to do with ketosis. Do you believe in that at all?
Yeah. Oh, wow. That's that opens a whole nother can of worms in terms of aging, but also cognition. So there's endless publications, again, mainly from Southern California, about starvation and about trying to avoid taking any nutrients for 12 hours a day or 3 days a week or something like that. And there are results, but I don't think I'm very sophisticated to analyze those. I think I echo what you said. There's interest in that. So whether that's all about creating ketosis, I don't know. On that happy thought, are we going to call it, Nicole, Sally?
We'll check on the chat, see if there's anything.
Well, I thank you all for coming. Appreciate that, and I hope you can spread the word that we need to pay attention to this and try to do better.
Thank you.
All right. Thank you.